Welcome back to the third day, and last day morning. Obviously, we know who the true hardcore fans are who are sitting in the chairs here, and so I applaud your presence. We have a great lineup of speakers this morning, and I want to start with introducing Dr. Mahmoud Razavi, who will give the first two talks. Dr. Razavi is currently the Director of Clinical Center of Clinical Trials and Research at St. Joseph Heart and Vascular Center in California. Prior to this, he was Associate Professor at Stanford University Medical Center and Director of the Fellowship Program for Interventional Radiology, where he actually interviewed me for a fellowship long time ago. So it's good to meet you again.
Looks like we missed one back then.
Yeah. So he's also served as Acting Chief of Interventional Radiology at Stanford University Hospital. He's authored or co-authored over 250 publications, abstracts, book chapters, and given over 300 invited lectures. Dr. Razavi is has served as editor and on the editorial board of several scientific journals, and is the founder or co-founder of 4 medical startup companies. It's our great pleasure and honor to have Dr. Razavi here talking about IR management of acute DVT.
Great, thank you very much. My charge this morning was to specifically focus on mechanical thrombectomy devices in the management of deep vein thrombosis, and that's what we'll be doing. These are my disclosures. And mechanical thrombectomy devices, up to now, there have been over 29. Now there are actually 32, so I need to update this. Devices have been used, and that market is growing. Back in the late 90s, the clot management became hot from a business perspective. So every time you turned, there was a new thrombectomy device out there. Then in the 2000s, it went completely cold from a perspective, again, of a business, not medicine, because the medical part of it didn't change. Now it's hot again. And so now every time you turn around, there's a new one. 11 of these are approved or cleared by the US FDA for the use in the United States. There are more of them available in Europe, but really not many get used. Only a few are actively marketed. The mechanisms of action are in 2 general areas. One is pure mechanical methods, and that is by aspiration or disruption and maceration, recirculation or energy assistance. And then the others that are lytic assisted. And these are mostly pharmacomechanical, really, mixture of lytics and drugs. And here's a partial list of some of these mechanical thrombectomy devices. On the lytic-assisted devices, really, there are 3 main ones that are currently in use. The trellis lines, trellis 8 and 6, which is 6 and 8 French. This line, actually, their new catheter that is coming out is about 30% more efficacious than trellis 8. And that has just been released in the US. I think it may be available out here and in Europe. And as these things go, they become available outside of US before in US. ECOS lysis system, which is also ultrasound accelerated lysis, and then the angiojet plus a thrombolytic in a power pulse mode, which basically is lytic assisted. Now, the advantages of using these mechanical thrombectomy devices is, number one, they speed up the process of thrombolysis in acute clot. And there's potential for single-session treatment of deep vein thrombosis, especially the upper extremities. It's not that hard to do it in a single session, on the table, clean the clot out. Lower extremities, the extent of clot is usually more than upper extremities, and especially if it involves the iliofemoral veins, that takes longer to clear out. These devices, use of these devices in combination with lytics allow you for single-session treatment. There is data to suggest that the dose of thrombolytic drugs are reduced when you use these systems. And you may be able to use them in patients who have otherwise contraindications to use of thrombolytic drugs. For example, recently postoperative patients. And here's an example. 67-year-old female, 5-day history of left lower extremity edema and pain. This lady, only 7 days status post spinal fusion. And of course, we know whenever central nervous system is touched, that's a contraindication to thrombolytics. I have done thrombolytic therapy 3 days after heart transplant. Vascular procedures don't bother me as much as, for example, a cancer retroperitoneal dissection or a central nervous system surgeries for various reasons. However, this patient, they've been in her spine, and they did a spinal fusion. Ultrasound revealed extensive iliofemoral DVT. We were consulted regarding this DVT, and my partner who consulted this patient, because of this post-op sort of history, decided to put a filter in. Now, an IVC filter was placed. However, the patient's symptoms worsened over the next 2 days, and it became significant. Worse. And I saw this patient this time, and we brought the patient back for a venogram and lytic, and here's the initial venogram. As you can see, a popliteal approach. My preferred approach is a low popliteal or high tibial in these patients when you can localize them. In an acute setting, as you all know, the veins are edematous and large, and it's hard to localize them, but you can see the artery. Once you can see the artery, you know the structure just posterior to that is usually the vein, and it's easier to get into them. Anyway, the access is obtained here, a wire is passed, and here's what the venogram looks like. A typical acute thrombosis and a partially duplicated femoral vein, as you can see right there. And here's what the iliac system and the common femoral looks like. All clots. Obviously, as you can see, there's no flow from the profunda or the saphenous, so the outflow from this lady is completely thrombosed, and this is why her symptoms are bad. She's at risk of phlegmasia at this point, and here's what it looks like higher up. Typically, there's a suggestion that up here, there may be a, my arrow, where's my arrow? Right up here, there's a suggestion that there may be May-Thurner. So this patient is prone, and this is left lower extremity. This is a typical May-Thurner looking feature, but we don't know really because there's so much clot in there. So we decided that we do pharmacomechanical on the table. We didn't want to give overnight infusion of TPA or urokinase in this patient, and we elected to use trellis. And here it is, the trellis being used in the iliac system, and then we came down and used it in the common femoral and then the femoral vein. And here's what it looks like in that femoral vein only about 15 minutes later, after use of lytics with the trellis system. As you can see, it's beginning to clear. This was all thrombosed 15 minutes before. And there's some residual thrombus down there in the popliteal vein, which obstructs flow. We can't leave it like this. This needs to be cleared. So this is some more, and you can see that valve right behind it is not cleared, and a few minutes later, everything is clear. So it took about half an hour to clear the femoral vein right there and into the common femoral vein with only 10 milligrams of TPA. The advantage of a system such as trellis is that theoretically you can pull some of your TPA out or urokinase because it's a double balloon system and everything in between theoretically is contained. The problem is in the venous system there are a lot of tributaries and collaterals that the TPA can infuse out. You can see it. But if those are thrombosed, everything stays within that system and you can pull after that, aspirate that segment between the two. It is difficult to know how much of your thrombolytic you take out, but we usually do that when we want to take the lytic out, as in this case. And here's what the iliacs look like. So there is residual clot here. As you can see, there are filling defects. There's a bit of flow. So we have established flow. The patient is out of danger. The patient is not in risk of phlegmasia. But we do have obstructive or residual thrombus there, which is not completely obstructive. So let me just, by show of hand, how many at this point would this leave this? Popliteal and femoral vein are not clear. We have inflow. This is what the outflow from the iliac vein looks like, and we're getting some flow out. Should we just stop and anticoagulate this patient? How many would stop at this point? Okay, and how many would stent this? Great. Yeah, the data when we did this was not clear, but it is very clear now from randomized studies that residual clot, even if you have flow, the patency of that vein is significantly less than if you stent those. So this got stented. And here are post-stenting. You see that there's now brisk outflow. Now, the stent, I admit readily, that was placed on top of acute clot. But that was obstructive clot that we did not want to lyse overnight. And I don't know of any mechanical system that can stand alone clean all of these out by itself without using a couple of hours of angiojet or something like that. So we left this patient, did great, symptoms disappeared. Patient came back 3 months later for removal of the filter. Symptoms had obviously significantly improved, but there was some residual ankle edema, probably because of the clot below the knee. And patient was anticoagulated. So when I was removing that filter, I couldn't resist but to go down there and take a look. As you can see, saphenous vein is open, and the valve is competent, and there's flow from the profunda. So all of those opened up very nicely. And here's that segment that we had stented on top of fresh clot. All of that is gone. So the limitations of mechanical thrombectomy devices is that there's a paucity of data to prove efficacy. There's very little out there. Comparative analysis is non-existent. Although there's so many of these devices out there, we have no comparative data between various devices. The long-term safety in terms of valve function and all of that is not well documented. And the major limitation is that they're largely ineffective as a standalone technique. So, and I'll show you some data. Again, very little data exists. But if you use them without thrombolytic devices, they don't work that well. And there is a device-dependent risk of pulmonary embolism. Look at this case. This is courtesy of Dr. Yi, who is an avid user of angiojet and pulse spray with TPA. And so here's, as you can see, occlusive thrombus in the iliac venous system. And he did this on the table with angiojet and TPA. And here it is, about 10, 15 minutes later. As you can see, a major part of that clot is cleared. And there's a little bit of residual clot in that common iliac vein. And he went after that and cleaned that too. The problem is that he thought he cleaned this clot. But all the clot is up here, behind the filter. So basically what angiojet did is just push the clot up and down. And that's what we have seen ourselves also, that you think you're cleaning these things out acutely, but it's really not. And of course now it's a good thing that this patient had a filter in. Now, this is the efficacy, if you summarize the literature, efficacy of catheter-directed thrombolysis in acute deep vein thrombosis using 3 different drugs, TPA, TNK, and urokinase. Pretty much very similar sort of efficacy. And this is where this 80-80 rule comes from, that for any thrombectomy device to be successful and replace thrombolytics, they have to clear 80% of the clot in 80% of the patient to be competitive with catheter-directed thrombolysis. And no thrombectomy device standalone currently does that, unless you have lytic-assisted devices, as we talked about. Standalone, some data, this is very old, but there's very little out there. Most of the data is now lytic-assisted. This one, they had 17 patients that they treated with angiojet alone. Only 4 of 17 were successful. The others were not. And 6 of 17 had 50 to 90% lysis. Out of those, 9 had additional catheter-directed thrombolysis. So it really doesn't work. And this parallels our own experience. So it really doesn't work by itself alone unless the clot is really fresh. Sometimes we use it in the upper extremities such as this. And you can see here's the Paget-Schroeder or thoracic outlet sort of syndrome. We can clean that out. And now we have the obstruction of the Paget-Schroeder. And this patient goes for surgical decompression. Mechanical thrombectomy devices, some of the more recent data. This is from Korea, from Dr. Kwon and colleagues, 27 patients. And they did aspiration thrombectomy in acute DVT alone. This is very misleading if you read the abstract. When you read the paper itself, you see that that was successful in 24 of 27 patients, and 22 of them got stents. So it's really not the mechanical thrombectomy device that was successful. It was the stents that reestablish flow, like that first case that I showed you. And this confirms the fact that mechanical thrombectomy devices by themselves, standalone, are largely ineffective. The only successful case that I have had because we persisted. Was this particular case, this guy is 10 days status post heart-lung transplant, and here's what the thrombosis looks like, and where the area of the recipient to donor SVC and anastomosis was problematic. So we cleaned all of that out, and there's a Pallmaz stent at the anastomosis, so got the flow going, and this guy actually did better. But this guy had good kidney function, and we could do this for an hour with angiojet and not worry about kidney function. So again, not very common. However, when you mix percutaneous mechanical thrombectomy devices versus lytic-assisted devices, you actually get good results. As you can see, here's a comparison by Dr. Kim of their catheter-directed reolytic versus catheter-directed alone. As you can see that there was a significantly different in the total dose of the urokinase and the treatment duration, which is what we expect. Here's a study, a retrospective review, patients with left lower extremity DVT. This came from I think, Peter Lynn's group, and here's the reolytic plus lytics versus catheter-directed. As you can see, the difference was the duration of treatment and the ICU stay. And the cost of therapy that you can see down at the bottom being less with reolytic plus lytics is all driven by ICU stay, which was 2 extra days in their hands. This result's actually very reproducible, and this is, in fact, one of the advantages of reolytics, that it can speed things up. Now, the only multi-center prospective study that was available up until recently, there are 2 randomized trials now using ecosystem in Europe, using it for DVT. We wait for the results of those. But this was a comparative study. As you can see on the left-hand side is the ECOS study compared to the National Venous Registry, and the right-hand side showing more efficacy using ultrasound-assisted devices. This is the results of a registry for Trellis. This is the first study that they actually produced, 147 patients. Those are the characteristics of those patients. I actually conducted this study, but there are a lot of weaknesses to this analysis. Having said that, it does prove something, and that is in patients who have acute clot, and that's the bar to your far left, most of the patients, greater than 90% of the patients, had significant clot lysis on the table. So you could potentially do that. Now, having used this myself and having been the guy who actually investigated and analyzed this data, this is multi-center data, by the way. I can tell you that Trellis, the old Trellis 8, probably not as effective in the iliac vein as it is in the femoral vein. The new system remains to be seen. As I mentioned earlier, they're 30% more effective, so we look forward to see what kind of data we can generate with that. So, conclusion is that the role of mechanical thrombectomy devices as a standalone mode of therapy in the treatment of DVT is limited for the reasons that we mentioned, and the data supports that. However, the combination of mechanical thrombectomy devices and lytic drugs is highly effective, and it can reduce the duration of treatment, and it can also reduce the dose of lytic therapy that could potentially reduce the bleeding complications, although that has not been proved at this point. Since I'm doing the next talk, I'll go probably straight into the next talk. If you guys could load up my next talk, and we'll go talk about from acute into a chronic setting and recanalization of the chronic veins. Thank you. An area that a lot of people find intimidating, and for good reason. It is very different than arterial occlusions. I'd much rather have a total occlusion of SFA and trifurcation than an iliocaval segment, because I know I can do that SFA and popliteal in less than an hour. When you get into the veins, we just don't know how long it's going to take. Disclosures. Now, central venous occlusions, Upper extremities, this is thrombotic disease, not non-thrombotic. Thrombotic disease is more common than the lower extremities. In the upper extremities, this is, again, symptomatic that present with symptoms. So if you look at the national statistics on DVT of 2 million per year only in USA alone, most of those are lower extremities, but most of those don't present for treatment. Those that present for treatment, upper extremity is more common. Malignant obstruction is the most common. Benign etiologies like dialysis-related central venous catheters, pacer wires, thoracic outlet is rapidly increasing, and that's because of the number of catheters and accesses that are placed through the upper extremities. Unfortunately, a lot of those are placed through the subclavian veins rather than the jugular. That causes problems. In the lower extremities, really majority are thrombotic and post-thrombotic venous disease and compression syndromes. Those of you who are doing greater saphenous vein and all that are aware that there is about a 20-25% correlation of May-Thurner or compression syndromes that occur at the same time as venous reflux disease. And that's becoming very popular in evaluation and ultrasound evaluation of the iliac systems. If you're doing superficial venous system, you'll pick up a lot of disease. And there is now good data to suggest that those patients that are stented actually do better after treatment of superficial venous disease. Occlusions, anatomy. When we talk about central venous occlusions, we're talking areas central to the thoracic inlet, which is brachiocephalic veins and the SVC, and central to the saphenofemoral junction. There's a lot of stuff in the literature, most of it coming from one of my ex-fellows, actually who's at Stanford now, talking about the trochanter. I wouldn't worry about the trochanter. Where you need to really look at in terms of assessing the efficacy of a stenting is where the saphenous drains into the femoral vein. So the saphenofemoral junction is the critical area. These patients are not always symptomatic. We treat based on symptom. In an asymptomatic asymptomatic patient, we don't treat those. There's no reason to treat them. Criteria for significant stenosis, for example, if you're doing a superficial femoral disease and you find that there is a compression of the iliac vein, what constitutes significance? There are three criteria. One is presence of collaterals. This is what I use. So when we do a venogram, if we see collaterals, that has to be significant. The other one is presence of gradient of 2 to 3 millimeter. 2 to 3 millimeter is enough to be significant in a recumbent patient in the venous system. The problem is the errors of measurements of our systems is about 2 to 3. So it's hard to know. Our surgical colleagues use the area of stenosis of greater than 50% using IVUS, intravascular ultrasound. None of these have any proof in the literature that one is better than the other. We're now conducting a study correlating presence of collaterals to the IVUS, and as you know, there are now 3 trials being run simultaneously in Europe and in US for venous stents. So we'll have an opportunity to study all of these, and hopefully in a year or two, we'll have more answers for you. As a general rule in these patients, sometimes more than one access is needed in chronic occlusions. If a chronic iliac occlusion, you may have to go through the jugular and the popliteal or femoral and jugular or something like that at the same time. It wouldn't be unusual to have 2 accesses. The length of the procedure is unpredictable in chronic total occlusions because these are fibrotic veins. And if you do a CT scan in many of these, you'll see that there's a contracted residual, so there's string of vein or tissue in those areas. I mean, I have recanalized IVCs that were documented occluded for 42 years. And when you do a CT scan, there's nothing there. And radiologists read that as cable agenesis. Well, it's not agenesis. Most of what they call venous hypoplasia or agenesis is actually chronic occlusion. It's not a non-existent vein. Most common element of success, planning, persistence, and practice, practice, practice. You really have to have patience in these things. And the current devices are not designed for venous occlusions. We pull the stuff that we use for arterial recanalization and use them here. As a general rule, sharp recanalization may be needed in many of these cases. So be familiar with devices for sharp recanalization and be comfortable with it. You have to have a comfort level to take a transeptal needle and push it through an SVC or a brachiocephalic vein, knowing full well that the aortic arch or the brachiocephalic artery is right next door. So you have to have some comfort level. IVC is much easier. Because if you go out, no big deal. You just come back in, it's a thrombosed segment, nobody cares, nothing happens. The brachiocephalics is a little bit trickier, and the SVC. Must be familiar with expected course and curvature of these veins. Now, this is easier for radiologists than non-radiologists because we are used to these things and we sort of know where these things are, and inherently in our heads, we usually correlate that to the CTs that we've looked at every day, and you sort of can guess where things are. And it's easier for us to go from oblique to oblique and sort of guess things. Some of our other colleagues need to become familiar with these courses before they start putting needles in these veins. I use transeptal needles all the time, and in one of my talks to our vascular surgery colleagues, we were talking about it, and I showed about 10 or 15 cases of transeptal needle usage, and one of them decided to use it when they went home, and he got in trouble. So you have to be very, very familiar with the course of these veins. Angioplasty alone, rarely effective in non-dialysis patients, but dialysis, it works. In non-dialysis chronic occlusion of veins, angioplasty just does not work. You have to support that with stents. And bare metal stents are associated with poor patency in veins peripheral to the brachiocephalic vein, that's subclavian veins. I don't stent subclavian veins unless it's a last resort, and now we're putting stent grafts in them. And lower than the saphenofemoral junction, and there are exceptions to these. But there is one particular group in the US who's a very avid proponent of stenting the entire femoral vein. It doesn't make sense, because even if you do that, you open up the valves chronically, and when the patient stands, it's a standing column, so they get symptoms of post-thrombotic syndrome. Here's an example, 76-year-old female, right upper extremity edema, so on and so forth. Here's the history, multiple lines. Now highly symptomatic in the arm. Now the reason I showed this, you can see the reconstitution of that. There's a distal brachiocephalic occlusion. There's a reconstitution of a little vein just below that. That is not the SVC. That actually happens to be the azygos. So that's not your target. Your target is straight down from that thing down in the chest. For the SVC, and can you, here's the movie of this thing, and you can see, now that is the back end of a hydrophilic wire, okay, straight down in the SVC, and you go follow that with a catheter, and here's the path you can see. Now that's the SVC down below. If you're not comfortable with that, it is very easy to go from the common femoral vein and put a picture or a balloon up there so you know exactly where your target is. Once you become comfortable with these things, then you can do it without knowing where your target is. And then this is after angioplasty and stenting with resumption of great flow. Now, some pitfalls. Main channel is not always clearly evident. Okay, so if you got chronic occlusion and multiple channels going out, sometimes you really don't know where is the main channel that you need to put your wires and catheters and dig. And you have to do various projections to see what that is. Nowadays, maybe a little bit easier by doing a three-dimensional angio on the table, so that makes it a little bit easier. Collaterals may be mistaken for main channels, and if you put a balloon on a collateral, it may rupture. Rupture also possible in the main channels if you overdilate these things. Our surgical colleagues are mainly influenced by one school of thought in US coming out of Mississippi that oversizes their stents. They put a 22 or 24 millimeter wall stent in an iliac vein. I've never seen an iliac vein that's that large. So and they are in the literature, and that thinking gets propagated, so they oversize these things, and it's not a good idea. Here's an 18-year-old female, chronic left lower extremity post-thrombotic syndrome. This kid a year earlier than that was in Mexico, got appendicitis, got surgery over there, and they basically nicked her vein, and things went bad, and now she has chronic occlusion. And here's the chronic occlusion. The patient, highly symptomatic. This girl happened to be a gymnast. So we did the initial venogram through the popliteal. As you can see, that the common, the external and common iliac veins are completely gone. And here's what the channels look like. The question is, well, which one is the channel we need to dig? And so we did a different projection, and here's what we see. And believe it or not, none of those are the channel. In fact, the channel that you need to be picking is somewhere in here and out. It's not this. Clearly, it's not that. But if you do it only in this projection, you would think that this is your main channel. But in a different projection, you see that's clearly not it. So we were not successful to recanalize this from below. So we turned the kid around, and we went from the jugular vein, came from the top. And here's from the top, and partially recanalized. And you can see in the image on the right side, I have my target down below, and I know where I need to sort of go down. And we did sharp recanalization, past the wire. We couldn't, once we passed the wire, I had to switch to 014 because nothing 035 would go through those fibrotic veins. And that's a coronary balloon there. So we started with 2 or 3 millimeter, just gradually dilate this thing up. And here's, as you see now, we switched to 035. Now we are gradually dilating and stented the whole thing, post-dilated, got the flow going. This was done about 12 years ago. The last file, this patient, actually, his kid moved to Philadelphia, and I had one of our colleagues in Philadelphia follow her up. And the last follow-up I have from her was 5 years ago, and she was doing great. So the approach, obviously, thrombolysis, anticoagulation, and angioplasty alone are largely ineffective in chronic total occlusions, and they have limited applicability in this setting. Stents are needed in majority of central venous occlusions, non-dialysis patients. Stents used as the last resort in outflow circuit in dialysis patients. That's my sort of take on it, but I think data supports that. Stents, iliacs and common femoral veins 10 to 16. Now, you guys out here have access to 16 millimeter stents. The only option we have in the United States are Wallace stents, which is not very good for this application. Nitinol stents are better. And IVC, there's only one option, and that's Wallace stent. Superior vena cava, I personally prefer balloon expandable stent, especially when you get close to the right atrium. You can go into the brachycephalics and anchor them if you like, and I will show some of those. In the brachycephalics, I like nitinol stents. And subclavian veins, again, avoid them. We do it as a last resort because they will thrombose. If you look at points of confluence of veins, the one on the left are the brachycephalics. The one on the right are both common iliacs are out. At the points of confluence, how do we stent? What strategy do we use? Well, there are a few options. One is to do double barrel. Well, you do something like this, okay? If you do this with Wallace stents, there is a pretty high likelihood of thrombosis, actually about 30 to 40% rate of thrombosis, because the Wallace stents act like diaphragms. If you look at two Wallace stents next to each other, they look like two circles. So you have a lot of room outside of those that could be the nidus of thrombus. You could use this kind of sort of a Mercedes-Benz approach where you put one large stent into the main channel and then two stents sort of kissing stents coming into it. This would be my preferred choice if needed. Or you could do a crush technique. The problem with the crush technique is this is a stent that's extending from the brachycephalic or iliac into the superior vena cava or the IVC. So you have to size it to the superior vena cava or the inferior vena cava, and so that stent is oversized for the brachycephalic or the common iliac, as it's seen right here. This is oversized, and these stents, especially if they're nitinol stents, over time they dilate to their nominal size, so they can cause a higher risk of restenosis. And then you come back from the side. Now the problem with this is you will jail this area right here. This is probably the best way to go. This is the easiest way to go. Now, a few years ago, back in 1997, we started experimenting with fenestrated configurations. So if we had a patient like this, and you can see both brachiocephalics and the upper SVC occluded, is that we created a fenestrated type of sort of figure like this. There is a stent going into the internal jugular. There is a stent going right to the subclavian. And these two stents are going through each other. Okay, so they're fenestrated. And both of those are dilated, so you can actually pass a wire from down here and unobstructed go here or there. And same thing here. As you can see, it's a fenestrated configuration here. Now, we wrote a paper on this a while ago, both in the veins and arteries, and we were very excited, patting ourselves on the back that we created something new. Everything has to be done this way. And we, unfortunately, did not write any follow-up on it. When we look at our 5-year data on these, there's a very high rate of reocclusion and thrombosis, both arteries and veins in this area right here, because of these. So we have given up this approach. Unfortunately, again, I see a lot of people using it, referring back to our early work that, hey, fenestrated stents, people are doing it and it works nicely. We just didn't give them enough follow-up. So I wouldn't use this approach. 20-year-old, again, more example, has had lymphoma and occlusion, and here's what the SVC looks like. When I see something at a rounded sort of bottom like this, I hate those. These are very difficult to do. There's no way a wire could get past that. The wire just bounces around. You have to use a needle, a sharp needle, and that's what we used. Here's a transeptal needle coming from the top, and this is what you don't want to see. This isn't the pericardium, okay? So you don't want to have a venous system under pressure drain into the pericardium. So you have to quickly, at this point, find your way out, and that's it. We came from below and got through, ballooned it, and that's post-ballooning, and stented it. Now we're good. Another example, 42-year-old, high-altitude exercise intolerance with prominent superficial veins on the abdomen and pelvis. History was significant for prolonged umbilical vein catheterization after birth. This is a 43-year-old female. And this is what it looks like. As you can see, both iliac veins and the IVC are gone. We had access into both common femoral veins and the jugular vein and came from above and below and recanalized the entire thing. And here it is, as you can see, again, small balloons and things to open up our path through these fibrotic channels and stent it, and now a sort of a double-barrel stent. Note that IVC in this case, these are fibrotic channels, very difficult to dilate them. That's a 20-millimeter wall stent, and that's probably a 10-millimeter lumen that we were able to get out of it. However, the patient became asymptomatic and went away. In terms of outcomes in the upper extremity, malignant SVC syndrome, patencies are very good, as you can see. And the reason for that is because most of these patients die. So the objective of treatment of the SVC in these settings is for symptom relief, and while the patient is alive. And the bottom line, this is not a meta-analysis. This is just an average patency of what's in the literature, and that looks pretty good. Here it is for benign SVC, and as you can see, the primary and secondary patencies are significantly lower because we have longer follow-ups on these patients. And so therefore, as expected, the patencies are slightly lower. Lower extremity central venous occlusions, the acute technical success in experienced hands is about 80 to 92%. So it is with your patients that have saphenous reflux. And you're treating those and you see a stenosis or obstruction in the vein. Those have actually better than 90% patency. Outflow stenting, this data comes from Raju. Neglan and Raju are the two who have written extensively on this, both thrombotic and non-thrombotic, and their data is also confirming the data from other centers. And the non-thrombotic, the patency rates are quite high. In the thrombotics, that means the patient who had a DVT occluded, you opened it up and stented it, their patency rate is not as good as National Venous Registry. As I mentioned to you, it was 74%. In our hands, it's actually 82% in our patient population of over 500 patients. But that's just the experience and the patient selection. Significant reduction in pain and swelling in these patients, and symptoms improve significantly. These guys stent, and we have started stenting also in those patients who have axial deep venous reflux, not superficial, but deep venous reflux, where there's very little other choice. And they have ulcerations, venous ulcerations, we stent their outflows, and they do a lot better. If they don't, I have started actually embolizing their femoral veins, because surgeons ligate those in a severely symptomatic ulcerated patients with deep axial reflux. And you get some healing of ulceration in those patients. So conclusion, symptoms of central venous occlusion. Symptomatic central venous occlusion requires, obviously, reestablishment of flow. We don't treat asymptomatic patients. Endovascular approach is the first line of therapy. A lot of people asked me questions when I said endovascular is the first thing for critical limb ischemia yesterday. But I acknowledge that surgery is obviously the standard of care in those patients. In this setting, it's not. Surgical venous bypass is a very morbid procedure. It's not the first line of choice. Endovascular is. Familiarity with the venous pathophysiology is a must for us as the IRs, with the venous course and anatomy for our surgical colleagues. Thank you.